All right. Good afternoon or good morning, depending where you are joining us from. Thank you all so much for taking the time to join us for this webinar. Healthcare facilities and systems are faced with empowering and educating their frontline staff to return to excellence while dealing with a new nursing workforce and burnout of tenured clinicians. This webinar will highlight key challenges in the industry and how leveraging the right internal stakeholders, as well as simple evidence-based methodologies, can enable staff to return to basics to drive zero patient harm for top quality nursing initiatives. This webinar will be led by Angela Newman, Medline Senior Director of Clinical Services. She leads a team of over 40 field-based clinicians specializing in urology, vascular, respiratory, skin health, and perioperative. She has also spearheaded the development of patient safety solutions tackling CAUTIs, pneumonia, SSIs, bloodstream infections, and safe patient handling. Prior to Medline, she spent 10 years as an adult critical care nurse and 2 years managing the critical care unit at a large hospital in the Chicagoland area. Newman is a member of the American Nurses Association, American Association of Critical Care Nurses, and the Association for Professionals in Infection Control and Epidemiology. Newman is an active member of a variety of clinical professional organizations, including partnerships with the American Nurses Association, American Association of Critical Care Nurses, Sigma Theta Tau, Association for Vascular Access, and APIC. Newman holds a Bachelor of Science in Nursing from Rush University and an MBA in Healthcare Administration from Western Governors University. Please use the chat for all of your questions during the presentation, as we have 15 minutes allocated for a live question and answer. We will also be providing a toolkit with the presentation and 2 white papers highlighting our partnerships in reducing hospital-acquired conditions. With that, I will turn it over to Angela.
Thank you so much, Katie, and thank you all of you for joining today. This is a topic I'm very passionate about because it is a great time in healthcare to re-energize, re-empower, invigorate your staff, specifically related to patient safety initiatives, as well as quality indicators. So just so you know, as a disclosure, I am an employee of Medline Industries, and what I really want to share with you all over the next little bit is to talk about where we're at in terms of patient safety. I know we're probably all over the term pandemic, pre-pandemic, post-pandemic, so I'm going to refer to it as, the new era in healthcare and how that affects our quality programs. We're really going to take a look at how can you create a bundled and tailored approach for these quality initiatives and strategies at your facility using a people, process, product framework, and then really dive into how can internal partnerships really help drive these initiatives. Because if you don't have your buy-in throughout your facility, throughout your organization, you're not going to see those key metrics really hit those goals that you want to hit. So I think, when we talk about this new era of healthcare, there's a lot of factors that are playing a role in why we may not be hitting our goals in terms of patient safety initiatives. And they fall under 4 categories. I'm going to go in a little bit more detail, and they've evolved over time, right? So if you think about staffing challenges, we had a lot of challenges throughout the pandemic, but now we're starting to see this shift into this new world. And how does that affect how we take care of our patients? We also are struggling with educational preparedness, not only of our new nurses, but of our seasoned nurses, keeping their education on the forefront, keeping their best practices and the changes in practice top of mind. You're going to hear me talk a little bit about missed nursing care. I have a lot of opinions on this and a lot of feelings on this, but hopefully I frame it in a way that is more about how can we enable our staff to not have to miss or to not ration care. And then the access to supplies and other resources throughout your facility is so important to enable success of your teams. So the first thing we have to talk about is our nursing staffing crisis. Now, it's been well documented even before the past 3 years that we had a shortage of nurses. We also had challenges with nursing schools. I know it's a lot in the media right now about how we're turning away applicants, but we had this problem beforehand. However, the past few years and the changes in healthcare have really made this an exaggerated problem at this point. So what we're seeing is there's a lot more vacancies in registered nurses roles within the hospitals. And that's what this data is showing us, that more hospitals have higher level of vacancies. And what that tells me is that we just can't fill them as fast as we'd like to, right? And so how do we adjust for that? Also, I think that this is probably a conservative estimate. I get to talk to a lot of different care providers throughout the country, and I've heard in some cases, depending on the part of the country, up to 40–50% vacancy in their nursing staffs. However, there is some good news, right? So one of the challenges is that we are seeing a lot of turnover in terms of our nursing staff. And turnover is very expensive because not only do you have to then make up for that staff that is leaving in terms of hours. So maybe you're paying overtime. Maybe you are using traveler nurses. Maybe you have mandatory on-call that you have to pay. But then to get someone new into your facility to onboard them can be very, very costly. Now, while we have high levels of vacancy, as I just showed you, we are also starting to see a decrease in the amount of turnover, meaning we are keeping people in our facilities a little bit longer. Some of the activities that I see, and you may be doing this at your facilities, is sign-on bonuses, better benefits in terms of education and tuition reimbursement, better scheduling efforts, and the ability to make your hospital much more a positive place to work, right? Whatever the benefit may be. So we're starting to see the turnover decrease. It's still very high, but that should help you keep your staff and retain your staff for longer. And we know that if you can keep staff and have them be yours, you're going to save even more money. Not only do we look at travelers and how expensive they are, but you don't have to go through that process of, onboarding a traveler, having them for 8 weeks, the cost associated with that. So there are still challenges in terms of we have high turnover, but it is much, much better. What we are seeing, though, is a lot more novice nurses. So there's a couple of reasons why we're seeing this. One, we have a lot of new nursing staff coming out into the workforce that before we used to have this, if you don't have any experience, we're not going to hire you. Now we're hiring people before they're even graduated from nursing school, right? We also have a seasoned team of nurses that are leaving the profession, that are resigning or retiring early. It's been a lot to bear for those nurses the past few years being the tenured staff. So what we're hearing a lot of is that there's novice nurses in your facilities, and that can be problematic because they don't have the experience. There's so much of nursing of intuition, and I've done this before, so that makes them very uncertain. They have a lot of fear of making mistakes. So you see that you can have an increase in patient safety events. But what we are seeing with the younger generation is higher levels of burnout, higher levels of moral distress in the profession. So it makes them want to actually leave the profession or change their role much quicker than you might see with our tenured staff. So you're constantly having these new nurses coming in. And that's where a lot of these programs looking at retention are so vital, so that you start to get your core staff. And there was a great survey. It was about 17,000 nurses that gave their feedback. And so we had 30% on that survey say, I probably am going to leave the profession, or I'm probably not going to stay doing what I'm doing. So that means going to other areas of care. Maybe it's coming to industry. Maybe it's doing education. So we still are going to have this snowball effect and this rotation of all of these nurses coming in and out. So when you think about your quality programs, you're really lacking those team of nurses who've been there, done that, and can help support you. Along with that data, this survey also looked at the nurses' perception of the care they provide. So in the survey, 63% said they were satisfied with the quality of the care they're providing their patients. Now, to me, yay, it's above 50%, right? We're really happy with it. However, it's decreasing. Every year, the perception of care is going down and down. And we know that if our nurses are feeling that, our patients are ultimately feeling that. And it's those younger generations that are actually rating the quality of their care they're providing as much less than some of our tenured seasoned generations. And so what does that do on top of creating these safety events or creating the risk of these safety events is it's creating more of that moral distress and burnout for these clinicians. So how do we re-engage them? How do we get them feeling like I'm doing a good job every single day I come in to take care of my patients? Now, another data point that this survey looked at was their perception of the time they spend with their patients. So when you think about safety programs, whether it's falls prevention, whether it's CLABSI, CAUTI, pressure injury prevention, all the interventions are done at the bedside, right? All the things we need to do for our patients happen at the point of care. While charting and documentation for core measures and compliance is very important, we have staff that feel like they're being pulled more and more away from their patient care, which in turn is taking them away from their quality strategies. So how can we balance what we're asking our clinicians to do? How can we prioritize the right activities and allow them to have more time with their patients? Besides the obvious, we need more nurses, right? Now, I mentioned the missed nursing care. Here's why it's something I'm very passionate about. To me, missed nursing care sounds so negative, right? No clinician that I've ever met in my 20 years has ever said, I'm going to go into my shift to do a bad job or to not do the right thing. But we have all these factors compounding why particular aspects of nursing care are just not done. Of course, a lot of it has to do with staffing and workload, but we have to think about the environment our clinicians are working in. How easy are we making it for them to do the right thing? We talked about the novice nurses. Do they have the experience and the know-how to implement? Do they have the confidence to implement some of these strategies on their own? Resources are always a challenge. It's not just resources in terms of staff on the unit. It's support resources. It's our patient care techs that are able to go and turn our patients and give us an idea of what's happening on their skin. It's our education staff who can support us and help us critically think. So, there's a lot of resources that help keep these quality strategies going and make sure that we don't miss vital care for our patients. And then another area is communication and care coordination. There are so many handoffs in healthcare. And a lot of times, I know I did it personally in my past life. I'd be like, oh, I didn't get to this on my shift. Can you work on it on your shift? Or can you make sure you get it done? And while a lot of times, the nurse will write it down in their report, sometimes it's not clearly communicated that I didn't do this activity. Sometimes they don't get to this activity. So it just snowballs and very important interventions may not get done for very long periods of time or at all. So how can we think about how clinicians are rationing their care, using their time wisely? If they are saying they have very small amount of time with their patients, they're going to try to do as much as they can, but obviously they cannot do it all. So we have to think about the missed nursing care. And there's a really great meta-analysis of about 42 studies, and nurses are reporting in record numbers across these studies, up to 98%, that they are missing important care in terms of their patients. And it could be something as simple as oral care, putting on moisturizers, little things like that that can have a big impact on your patient's health. Now, a lot of talk about supply chain and the resources have been focused on, the availability of supplies and maybe more focused here in materials team or your supply chain team. However, supply chain has a significant impact on your nursing care. There's been a lot of substitutions. There's been a lot of kits run without products, and nurses aren't always privy to that information. They're going to pull their supplies, go into the patient's room, and then look and say, oh my goodness, I'm missing this, or I don't have this. So in this survey, we had a high percentage of nurses saying they have to look around for supplies, and they've even stepped away from patients in the middle of doing care to get more supplies, which we know is going to have a patient safety risk, whether it's a fall, whether it's breaking your sterile technique, whatever the case may be. Another issue that nursing is experiencing with supplies is, as supply chain has been really creative to try to get either similar products or, create new products, sometimes that affects the shelf life of the products available. And nurses aren't necessarily looking for product expiration. And if you think about the efficacy of some of the products related to CLABSI, central line associated bloodstream infections, pressure injury prevention, some of the lotions, if a product is expired, it might not have the same efficacy as it would if it isn't expired. So our clinicians may be using products that aren't appropriate at that time or have decreased efficacy, and they're just not spending the time to look for it, nor do they have the time to look and see our products expired. So we have to think about how the supplies available can really affect their care. Also, a lot of these changes, products are used very differently. I was working with the healthcare system on the West Coast. They had 3 different types of chest tubes that they kept subbing in just because they needed to have some chest tubes. And one of the things was that one of the chest tubes was not able to be in an MRI machine, but the staff were not aware of that. So that's another patient safety issue. If the product is slightly different and there's something that could affect the care of the patient, we need to make sure they're aware of these changes in the products. So I hate painting the doom and gloom, right? Like, we know that throughout the pandemic that we had patient safety events go up tremendously, and they're still in some areas on the rise. Before the pandemic, though, we were doing very, very well in terms of hospital-acquired events. Actually, the only quality measure that was on the rise was pressure injuries. But we had SSI going down, we had C. diff, hospital-acquired MRSA, CLABSI, CAUTI, they all were decreasing. Obviously, when you have such a change and so much happening in your healthcare facilities, we anticipate the numbers to go up. What's really interesting is that obviously adding more work to the clinicians isn't the answer. And there is data in this case that shows the more patient load you add to your clinicians, the higher risk of mortality. So, we have more safety events happening with potentially a higher mortality rate. But again, it's not all doom and gloom. If you guys looked at the recent health grades from Leapfrog, we are seeing some tremendous improvements, specifically in hospital-acquired infections on the SIR rates. So CAUTI is actually down to its pre-pandemic levels, which is really fantastic. And we've seen tremendous improvements for CLABSI and MRSA. However, there's still a lot of work to do just to even get back to that 0 period. So what CMS has come out with is their national quality strategy. And what I like about it is it's a long-term plan, because I think a lot of facilities that I get to work with, they come out with very aggressive goals. We need to get back to pre-pandemic in a quarter. That's really hard to do. And there's a lot of work that needs to be done in order to make it a sustainable change and make it your new habit, your new baseline. So what this quality initiative really looks at is, okay, we know we have a variety of hospital-acquired condition rates throughout the country. Some people are doing great here, some people are struggling here. It's all over. But by 2025, we want to be back down to pre-pandemic levels. Now, that seems like, okay, that's a great goal, but I just want to remind everyone on this call that 2024 is about a month and a half away. So we are about a year away from really trying to be back to those pre-pandemic levels. But what CMS is also stressing is we got to continue to reduce harm. So their goal by 2030 is to continue to reduce by 25%. So we have to build strategies within our facilities that, again, are going to survive the long term. It's not going to be, hey, CLABSIs are up this month in my unit, so we're going to do a big campaign, but then pressure injuries are up this month, or SSIs are up and we're going to lose focus. We have to maintain focus on all these initiatives. I love this quote. It actually comes from an ANA article, but really at the heart of it is, when you're looking at quality and the highest of quality care, there are so many people involved and there is a lot of collaboration that needs to happen. And what I really want to stress to you all is that You have to think about your healthcare facility in terms of microsystems and in terms of how do each of these areas operate, what is their motivation, what is their roles of responsibility in safety strategies, because then you could start tailoring your intervention. So this is just an example, but there's so many different microsystems within a hospital. And again, these are just some examples. When my hospital, we always kind of felt like we were our own unit as critical care. And then we looked at OR as completely different because it was a completely different environment, and ED and med surg. So when you start to think about, okay, where do I start? We have to think about all the players who are going to have a say in terms of how do we reduce these safety events. And you need to think about who are your stakeholders. So we know that you're going to have a bulk of internal stakeholders. There's going to be a lot of people with a lot of opinions who have a lot of expertise that you may need to be involved. But there's also external stakeholders, whether it's vendors, whether it's patients. They also can really guide your safety initiatives. So we have to look and map this all out. And AHRQ has some really great tools. Please don't reinvent the wheel. There's a lot of great resources that you can use. But I think one of the first things you have to do is, who are our key stakeholders? And really identify, are they an influencer? Are they invested in this change? Are they going to be one of the change agents? Are they just going to be someone that needs to be in the know that you're potentially looking at making a change? And I would highly encourage to have people from various levels of your organization. I was working with a facility here in the Chicagoland area, and I was doing some interviews of some bedside staff just to, get the temperature of how they're feeling about their safety initiatives. And what we heard resoundingly from the bedside staff was, hey, these ideas are great, but it's very clear that they didn't have a bedside nurse give feedback. It's very clear they don't understand some of the workflow challenges we're having. So highly recommend having everyone invested. And if I'm a new novice nurse trying to, make my mark, and you're really trying to recruit and empower your new nurses, this is a great opportunity to have them involved in your patient safety initiatives. But they have to be interested. You can't, choose Nurse Nancy just because she's really good at what she does. You have to make sure she has an interest and it's going to be invested in it. I also would say consider people who are going to contribute to the success of your initiative, but also consider blockers, because you really want to have that insight into why someone may not be on board or why someone may have a differing opinion of what your patient safety initiative should look like. And definitely have people that are influential throughout the organization, but also have an expertise in this area, or have good technical knowledge if it's a procedure that might be involved, such as CLABSI prevention or CAUDI prevention. You want to have people that know how Foley catheters are put in, how they're maintained. So start to identify, use the tools from AHRQ, and really map out who needs to be involved in your patient safety initiatives. I'm going to walk through an example of some of the different microsystems, how they might influence a quality initiative, and then how some of the stakeholders might be involved. So take, for example, central line associated bloodstream infections, right? You have a lot of different systems that have a play in it. So you have value analysis who may be making decisions on products and the products available to your staff. You have intensivists, for example, or maybe ER docs or OR docs who are inserting central lines. So there's practice involved there, and then there's use of the product there. You have critical care staff that are going to be assisting the line being placed, taking care of that line. Maybe they've never taken care of a central line. Maybe they've never been involved in the insertion of one. So how can they, really influence the maintenance side of a central line? We have infection preventionists, depending on how active they are in your facility. Maybe they're doing rounds on all the central lines. Maybe they're pushing every day to get central lines out. So they have a play in prevention. If you have a PIC team or a vascular team at your hospital, a lot of times what we see is once the patient goes to general med surg and they still need to have that line, the PIC team may be maintaining that line throughout the rest of the patient's day, but what are their hours? What are their availability? How many patients are they maintaining? Are they able to get to a patient right away when there's a problem? That absolutely can affect your CLABSI prevention. And where is nursing leadership in this? Do they have strong goals tied to CLABSI prevention? Maybe they don't feel like CLABSI is a challenge this year, or maybe they are very invested and they're looking at your line days every single day. But now you have to start thinking about what are the external forces working on our stakeholders. So vendors are, can be working with all these different teams in a variety of capacities, and who is putting it all together, the work that's being done. So your vendor might be working with value analysis to provide cost savings on a product. They may be working with your intensivist to build a custom kit. They may be working with infection prevention or nursing leadership on an all-encompassing educational platform. How do we bring that all together? And then think about your patients. Your patients can really play a part in how your strategy is built. So if you live in an area and maybe you have high rate of dialysis patients, so they have troubling vasculature or difficult vasculature, how does that impact what type of devices you're using, and maybe your decision tree for when to give a patient a central line? So this is just one example, and I highly encourage you, once you start identifying your stakeholders and what the different systems are at play in your hospital, start mapping it out, and you'd be really surprised where you might find some opportunities to improve your patient safety initiative. So one of the easiest ways to do it, and there's a ton of research, is to create a bundle. And this is from IHI. This is not anything new, I think, for a lot of us on this call, but how can we modify how the work is done, the culture, the supplies, the care that's being provided to really make an impact on our patient safety initiatives? And so what I say is you have to be very thoughtful and strategic about the interventions you implement. It's very easy when you start diving into this to find 20 things that you want to do. However, if you throw spaghetti at the wall, it's not all going to stick. So you want to have small interventions, and you may want to start in small areas, right? You may want to start with critical care because they see a high percentage of patients at risk for pressure injuries. So you might want to start the intervention there, and you have to make sure that the intervention is practical. You can't create an intervention. And I know this seems like common sense, but again, when you're building this, it's very easy to be like, oh, if we just do, Q2-hour skin checks, we're going to catch things much quicker. And hopefully that prevents us from having stage 3 and stage 4 pressure injuries. But how can your staff really work that into their workflow? Their head is barely above water as is. So creating small, practical interventions is very important, and you need to be able to replicate it. So maybe you do have to adjust it depending on the patient population or the type of unit it is. But what you do in one unit, you should be able to, broaden out, and also broaden out if you're part of a healthcare system. And this is a must, and I'm probably going to say this so many times, what you do needs to be measurable. So how do we know if something's working if we don't have data to back up that there's been an improvement or we've met our goals? So you have to look at your goals and what you are about to do and make sure that it has a measurable factor to it. Now, I'm not going to spend a ton of time talking about, quality improvement. There's, again, a ton of resources. AHRQ, again, has great resources. But I always like to share my spin on this and how it makes sense in my head. So I'm a former ICU nurse. We would do assessments every 4 hours, meet with the care team. We'd come up with a plan. We'd get some orders. We'd carry them out. And then I'd assess all over again and see, have we made progress? Oh, something new's popped up. Oh no, that didn't have the effect we wanted. That's how we have to really look at our patient safety initiatives, as if it was one of our patients we were taking care of, and that we have to constantly be reassessing and refining the plan of care in order to get the results we want. So how do you know where to start? I think as you start building out your list of, this is the area I want to look at, here's some key stakeholders, start defining goals. What do we want to accomplish? And then I referenced earlier, if you have 25 CLABSIs, you're not going to get down to 0 in a quarter. Let's be realistic in terms of our goals, and let's take incremental progress as a very good thing. So what can our goals be? Do they align across the organization? Do they align across our key stakeholders? who's really going to be affected by these goals. I also recommend like taking maybe a higher level goal, like we want to reduce CLABSI, and then start branching off and thinking about other goals related to that that's going to get you to that CLABSI goal. Maybe it's we want to reduce emergent lines in the ED. Maybe it's we want to reduce femorals. Maybe it's we want to reduce unplanned dressing changes. Start branching out and, you know, really getting into very specific goals so that you can start to look at what are the interventions that are going to make the biggest impact. And then again, make sure that they're measurable. If they're not measurable, maybe it's not the right goal at that time, or maybe you need to be more clear in your definition of what the goal is. So a really good way when you're thinking about microsystems, when you're thinking about creating this strategy, is looking at it from a variety of different aspects. And I know I work for a medical supply company, but I'm going to tell you right now, if you have a bad process, if you have staff that are not confident or don't have the right knowledge base, it does not matter what product you're going to use in terms of patient safety initiatives, you know, clotty trays, dressings for pressure injury prevention. You really do need to take a look at what's happening with our process. How are our staff well-versed, knowledgeable in the rationale of why we do certain things? And then the product should be last and should complement that. So we really want to focus on all three of these, but again, high focus on that process and your teams. So the biggest way to do this is to almost just dive in and get into the weeds, right? So you have to identify what you want to do versus what we're actually doing. And this gap can get wider. And there's a lot of times when you start doing this type of investigative work that you're going to find out things you're really uncomfortable with about your facility, or you are a little shocked that is happening. And that's okay, because that's a starting point. At my hospital, we were having an uptick in CLABSI. So what we did is, you know, we interviewed some staff, tried to ask about what was happening. Not only did we interview staff that were involved in the CLABSIs, but other staff. And we just started watching and observing care. We're like, hey, I just want to shadow you around. Let me understand your process for taking care of this line. And we found one of our opportunities was that the staff was using the bedside table for their kit setup, right? Their sterile kit setup. However, on the table was dentures. There was the urinal. I think there was like half a sandwich that the patient wanted to save. Some clinicians were also using, you know, the soiled linen cart as their tabletop. And I know I used to put linens on top of it before, you know, while doing a dressing, you know, or changing the patient. So sometimes you need to dive in and find those gaps, as uncomfortable as it may be, to really then say, okay, where's our process not working, or where is there ambiguousness in our process? Now, we have to be careful about how we approach our people and their educational readiness or preparedness. But I think there's two areas that if you really focus on can have a tremendous impact on your patient safety initiatives. So the first is variation in care. We know that we are having some variation, as I referenced before, with supplies availability. But one thing that was always clear in my unit is you could tell who precepted who by some of their practices. Now, in some cases, that's really great, right? Whether it's organization or, you know, the willingness to look things up, those are really great practices. We want your preceptors to be putting that out. But you also can see like, oh, well, so-and-so uses this dressing because, you know, Nancy precepted them and that's their favorite dressing. They've used it for 12 years of nursing and that's what they teach their clinicians. Or so-and-so teaches their clinicians that they precept to, you know, toss all this out and just use these, you know, supplies. Or, you know, this intensivist likes to grab these extra supplies versus this intensivist. So reducing some of that variability is going to make a significant impact because it's going to reduce your risk. You're going to define your process as part of the planning stage, and then you're going to find where are there variations. And then a huge area is knowing the why. So there's so much as clinicians we do that there's not a direct cause and effect. There's a lot that we do that if I do this, this is going to happen. If I apply oxygen to my patient, hopefully their oxygen saturation is going to go up. But if I clean a central line for 30 seconds, let it dry for 30 seconds, I don't always see the benefit of that, right? And so we really need to focus with our team about why certain steps are so important so they don't eliminate it when they're overworked. They don't ration their care and eliminate certain steps. So it's really important not only to train them on the proper procedure, but why the proper procedure is so important. But it's very complicated, right? If you tell staff you're going to do a skills day, if you tell staff, we got an in-service, I'm sure you're probably getting some eye rolls because they are, really overwhelmed and overworked with a lot of that. So you have to start thinking about how can you be training your staff in a variety of different ways, but also training them on the proper process. So kind of, the tip of the iceberg is you have vendors come in and they'll train on products, right? And they'll say, this is the benefits of this product, this is how you use it. But if you start to think about, we want a process for our patient safety initiative, your vendors aren't touching that when you have so many vendors potentially coming in. An example of this is on pressure injury prevention and treatment. On average, you can have 20 to 30 vendors that supply your hospital with products. So that might be 20 or 30 vendors coming into your units and training your staff. They are training on this widget or this widget. No one's saying as a whole, when you have that many vendors, these are all the interventions you can use for friction and shear. And this is how you make a decision on when to use it. So start thinking about how can I have better vendor partners? How can I look at my formularies? How can I, incorporate the process in that training, whether it's as an adjunct to potential product and servicing that, yes, does need to happen, or reinforcing that learning over time. Maybe you get initial product training and then maybe in a month you do some type of other training, whether it's a huddle, whether it's, a poster that reinforces the process. So we have to think about that in terms of really understanding our clinicians in today's world, in the new era of healthcare, and their needs when we're looking at how complex some of these patient safety initiatives are. And finally, I'll talk about product, only because you need to be very thoughtful about product choices. A lot of times I know it can be a matter of cost savings. It can be a matter of, preference sometimes, but products should really reinforce the process you define with your teams. And you need to take in consideration what your end users need. And that's, from that example I gave earlier with the healthcare facility in Illinois, you could have got a lot of feedback from them on products that were being selected. And sometimes you can't always make the change to the product they want, but they're much more invested if they understand and are involved in the process. You also want products that are going to reduce the ability for clinicians to have that variation in care, that are, going to open up a kit and look at it and say, I don't know what I'm supposed to grab first, so I'm going to root around in it. And you also have to think about how your products are a part of your patient satisfaction and your patient experience. So, if Nurse Nancy does a procedure with a product one way, and Nurse Steve does it a different way, your patients do notice that, and they are educated or not, whether it's from Dr. Google or not. So you have to have products that are going to align to your process and have consistency. So what you want to do is you actually want to pull 3 levers with the same goal in mind, right? On the process, people, and the product. So you want to have 3 or more phases to this. And again, it's ongoing, but phase 1, which is probably going to be your longest phase, is your planning phase. Get your stakeholders involved, identify who those people are, look at, depending on what the initiative is, what the incidence is, what do we want to achieve, what is available go out into the nursing units, talk to staff, look at movement and whatever your goals are. You have to keep on it. You absolutely have to keep on it. And then phase 3 is studying and refining. You cannot have an intervention like this and then leave it. You have to keep checking in. You have to keep going back and doing that discovery of phase 1. So there's a lot of work to be done. However, once you get into phase 3 and you're refining, again, you're going to be in a good groove. You're going to have your stakeholders invested. You're going to start to see progress, and you're going to keep that ball rolling. So I just want to give you an example of something I did with the facility. Their goal was they were having unplanned dressing changes. So the INS recommends for a central line dressing that it should be changed every 7 days or as needed if it's, not clean, dry, and intact. So how did we take this people, process, product, approach to reducing unplanned dressing changes? So from the process perspective, we did look at the policy, and we found out through interviewing of staff that there used to be a dressing change day. And so we had staff that were still changing on that day, even if the dressing wasn't soiled, versus the new policy and newer staff who were following the Q7 and PRN. So already we found a great opportunity there. And then we started rounding on all the dressings just to see, like, why aren't they sticking? There's a lot of opportunities here. Some of the docs were putting in the IJs, the necklines really high. So it's really hard for the clinicians to apply.
All right, we'll give Angela a minute to see if she's able to recover her internet here.
Am I back?
You are back.
Okay, I apologize about that. I will try to, be quick just in case I lose it again. Maybe I will turn off my camera just to make it a little bit better. So hopefully you guys heard that we developed an education campaign specific to different users of the dressing, but then we also found that there was a lot of dressings available to staff and there was differences in the kit. So we wanted to standardize that from a product perspective to reduce that variability. So what you're doing ultimately is you're taking what's best into what you're always doing, right? You're creating that bridge, and that study period when you're refining is going to strengthen that bridge there. So a lot of times I get asked, does this really work? This is a facility we worked with that used that people, process, products perspective, and they've reduced their pressure injuries by 69%. And again, as I mentioned earlier, you might not see a lot of, reduction right away, but this is consistently, putting the message out, retaining the message, getting it out there to the staff over and over in terms of, whatever the intervention was until you ultimately saw that reduction to 0. So where do you start? Start thinking about your goals, start thinking about your priorities. I think a lot of times some of these quality metrics like CLABSI, CAUTI, pressure injuries, SSI typically are top of mind, but start thinking about what some goals could be for you all and where you really want to make an impact, especially going into 2024. You want to recognize who these initiatives are going to affect, who are some key stakeholders. I can't stress enough, use the AHRQ toolkit. Because it's so helpful and vital and the tools already exist for you. And then start thinking about tailored interventions. Think about those different microsystems and what intervention might work for them or what is falling within their scope. And I can't stress this enough. Continue to refine. Partner with vendors that are looking at quality metrics, partner within your organization with, new nurses who are looking to grow their career, to grow their expertise, who want to stay at your facility, use your clinical ladder and use those resources. And again, you will see that long-term achievement to that goal. So thank you guys so much. I apologize for my internet. I had no forewarning that I was coming. If you have any questions, because I get to work with a lot of different healthcare facilities across the country and worked a lot with quality improvement. Here's my contact information, my email, as well as my cell phone. Please feel free to reach out. I'm always happy to brainstorm, to innovate, and talk about how we can improve healthcare for our nurses and our patients. So I will stop sharing and hope that my internet hangs in there.
Thank you, Angela, so much for the informative presentation. We do have a question here that came through the chat. Do you see differences in nurse staffing issues in different types of hospitals, such as variation between what you might see in a teaching hospital versus a safety net hospital?
That is absolutely a great question. We do. Teaching hospitals, especially those that have affiliation with nursing schools, typically do very well in terms of recruitment, because a lot of times you have that pool coming in for clinicals. I know when I went to Rush, it was kind of like a cuffing season a little bit, where in that like spring right before graduation, we had units and unit managers reaching out to us, looking for jobs, and I think obviously when you start thinking about rural hospitals where maybe there's just not a population of clinicians that exist, or the population is very small, it actually can be very competitive, and that's where those incentives, whether it's sign-on bonuses, retirement plans, are so important. So yes, there definitely is a big discrepancy, and also geographically as well. If you think about some states that have nursing unions and staffing ratios, it definitely can be positives and challenging as well.
Fantastic. Do you have any recommendations regarding measuring patient satisfaction?
I love this question as well. I think obviously we all get our HCAP scores and we look at them, and I was in ICU, we would maybe have one discharge in a 30-day period. So if we had a bad survey, it kind of set us off for a while. I know my CNO would look, and we had a scorecard and would be like, okay, Angela, what's happening in your unit? One thing I think is really important, especially for middle managers and even higher up leaders, do bedside rounding and have some key questions that you can have quantitative results from. So have your nursing managers do regular rounding on your patients, but have like 2 or 3 questions that they can then report back to the larger group. That's a really easy and quick turnaround time to get that impression of care, and it also allows you to intervene much earlier if you have a patient that may not be satisfied, maybe uncomfortable, maybe have a lot of questions about their care or concerned about their care. So that's something that we did, and I highly recommend it.
How has the growth in traveling nurses changed these trends?
So traveling nurses obviously has always existed. We in my unit, you'd always have that like time of year where you had like 4 or 5 people go on maternity leave, and we would use traveling nurses. I think traveling nurses are great clinicians in regards to, you need someone to step in, you need someone to be willing to come into a facility they're not familiar with, jump around. Sometimes traveling nurses don't always get the best patient assignments. But what we saw a lot of is that we barely had time to breathe. So we were barely even training these traveling nurses on our protocol. So they were relying on whatever experience they had. And so maybe they were working off of a protocol that is not, related or close to the protocol your team wants to use. So it allowed for a lot more of that variance. And to be honest with you, we gave all of our clinicians over the past 3 years kind of a carte blanche, like just do what it takes to get through your shift. So it really created, honestly, some bad habits, I feel like, in terms of nursing, in terms of like, just do what it takes. Don't necessarily, follow this protocol and procedure. So we definitely saw a lot of that. There are some studies that are coming out now, and I think we'll see a lot more in the next few, years that show that there's a higher rate of HAIs and HACs when there's travelers. But, to actually pinpoint it directly to a travel nurse is really hard.
What types of education modes are you finding successful outside of traditional in-servicing?
This is a great question as well. I think that we have to change and really adapt to our learners, right? We know that we have a wide generations of nurses that work in our healthcare facilities. And we have people that love the didactic, love getting, sitting down and, doing a PowerPoint. But we also have a lot of these new novice nurses that learn through simulation, that learned, over the internet, that learned on Zoom. So how can we create some really engaging training? How can we mix the different modalities of training into our plans? One thing that I'm hearing a lot of right now is because of so many of the new nurses doing a lot of their training with simulation, they just want hands-on training. So I'm hearing a lot of creating workshops, hands-on, applying nursing concepts to real life examples so that they don't have the necessary nursing background experience, but they can find something that they relate to, and making these sessions adaptable. You might not be able to pull staff out of staffing. You may be looking at your non-productive FTEs and say, I can't have people come in and sit in a 20-minute lecture. So can you make those workshops, traveling workshops, and they go to the units, or can you use posters, or, I hate to say it, but real style videos, short videos that are going to get those key concepts to your staff in small bullet points that they're going to retain. And you have to mix and match because you have so many different generations and so many different style learners, but be open to doing some of those other types of education.
All right. Well, thank you, Angela. And thank you everybody for, oh, wait, never mind. It looks like we have one more question here. Let me scroll up. Okay. The comment is, it seems that so much is ultimately about implementing the education process for staff. How much buy-in is there by stakeholders to implement ongoing education and evaluating the impact of the education?
That's a very good question. I think, and again, this is from my experience in my travels, that a lot of our higher level stakeholders are very invested and know that this is a gap, the education. I think if you are really thoughtful about putting together a long-term plan, and putting together a plan that can adapt to the fact that in 30 or 60 or 90 days, you might have a significant percentage of new staff, you're going to get a lot more buy-in. Everyone wants to just pull everyone out of staffing and do a skills day, and they feel better about it. But if you create a plan that, again, has those different stages, maybe it's short education, maybe it's reinforcement, month 2, maybe it's online learning. I'm seeing a lot more buy-in to that. There's a lot of different ways, though, that you can determine if the education was successful. Yes, you can look at how many staff members you educated, and then look at your staff numbers the next month and say, okay, how many percent of staff are new versus how many percent of staff are still here. You can, do different types of fun competency. I hate that we hand out quizzes or things like that, but there's a lot of games that we, Medline as a company, have been starting to build and share with different healthcare facilities. We also have scratch offs and things like that test knowledge and make it more fun and more hands-on and competitive. And then you can, look at the retention that way, like how many staff successfully completed it, how many staff, involved in this activity showed comprehension. And then obviously online, you can do some tracking. I know online learning it's one of those things where it's like a necessary evil, right? We all get at some point in the year 20 online modules, and we all click through them, do the quiz, and did we take anything away from it? But if we're, again, thinking about building a long-term plan, maybe we, implement a short microburst 10-minute online course that reinforces something we did hands-on 3 months ago, just to keep that learning top of mind. So I think building a plan, being very creative, and not just, hey, we're going to pull everyone out and do a skills day, but thinking about different ways of educating and reinforcing, whether it's short term, long term, whatever. And then identifying some specific metrics, whether it's people in, whether it's comprehension level, can really help you build your plan.
All right, I'll wait and see if another question comes through here. Give it another minute. All right, well, I think this time that is it. So thank you, Angela. Thank you, Leapfrog, for hosting us today. And thank you, all of you, for joining us for this informational webinar. And have a wonderful rest of your Thursday. Thank you.
Thank you all for your time.